The latest news, updates, and more from the world of health and medicine. This is Medical Minutes with Wish TV's medical reporter, Dr. Mary Gillis.
Joining me now is Dr. Nasser Hanna from IU Health. We're talking about smoking and the importance of getting our lungs screened. So let's kick it off with actually, there's a lot going on in terms of smoking. I mean, it's very dangerous. It's a comorbidity to a lot of to other conditions. So first, tell me a little bit about what we know so far and what's happening in terms of the lung cancer.
Yeah, well, I appreciate you inviting me. So November is Lung Cancer Awareness Month, and it's important to be aware that lung cancer is the number one cause of cancer-related death by far. That's true for both men and for women. And unfortunately, it causes more deaths every year than colon cancer, prostate cancer, and breast cancer combined. About 80 to 90% of people with lung cancer have a history of smoking for which the cancer can be attributed to. Now, that also means 10 to 20% of people with lung cancer have never smoked. And there are some risk factors for those individuals, including secondhand smoke, some exposures in the workplace, particularly things like asbestos and radon and other factory work as an example of that. And then there are some people who get lung cancer for which we don't have any identifiable cause, but about 80 to 90% is attributed to smoking.
Okay, and that's it's an incredible number. I mean, all those cancers combined, and this comes out at the top. And just really quickly, I wanted to talk about you mentioned secondhand smoke. There's been a debate about this, or debate in terms of the colleagues that I speak to. Tertiary smoke. So, I mean, you have someone who smokes, they go out and they, let's say, hug their friend, and then their friend goes home and hugs their child. I'm just curious. Sorry, I didn't mean to make a sort of detour, but what do you think?
No, that's okay. So what we know is that the same chemicals that cause cancer in the cigarette smoke that the person inhales is also present in the side smoke that they exhale or that burns from the cigarette. Many of those same carcinogens are present even, when it clings to your clothing. The concentrations are much lower. So it's a matter of duration of exposure. So a simple, brief exposure, it carries very low risk. The concern is when you have that chronic exposure, it's day after day, and that usually occurs either in the home or in the workplace.
Wow. Yeah, that's quite the chain of events there. And then also going back to women, I had read once that women are more likely to die of secondhand smoke than men from firsthand smoke. Am I wrong there? Is that correct? Or?
Well, it is true that secondhand smoke is attributed to at least 15,000 cases of lung cancer. Your risks are much higher for firsthand smoke. So the person who smokes. Women didn't used to smoke nearly as men, but they've caught up, and nearly as many women today smoke as men. And lung cancer used to be rare in men and women, and then it became much more common in men, but remained uncommon in women. Unfortunately, because of the decades of smoking, now women have caught up to men, and nearly as many women do die of lung cancer than men. So this is very much a women's health issue. And it's really important to know that you can significantly reduce your likelihood of dying from lung cancer with a screening lung CT scan. Mm-hmm. And to be eligible for that, you should be between the ages of 50 and 80 and have what's called a 20-pack year or higher smoking history, which means if you smoke 1 pack per day for 20 years, that would qualify. 2 packs per day for 10 years, half a pack a day for 40 years. All of those things equate to 20 pack years or more. And if you are between 50 and 80 and have that smoking history, you may be eligible for a lung screening CT, and that could save your life. We know that lung screening CTs reduce the mortality from lung cancer by at least 20%, and it's higher in women than in men. So if you're a female between the age of 50 and 80 and you have that smoking history, I would strongly encourage that in addition to your mammogram and your colonoscopy and your blood pressure check and your cholesterol check and all those other things that are meant to keep you well and healthy, that you talk to your doctor about a lung screening CT. In contrast to colonoscopy, which can help prevent colon cancer, and mammograms, which can detect breast cancer at a very young age, very few people who are eligible for lung screening scans get them. Over 70% of women get their mammograms. Over 70% of men and women get their colonoscopy, but only 10% get their screening CT.
Dr. Hanna, why do you think such a disparity? This is incredible. And also women, I just don't think of women as being at risk. And I'm just wondering, I don't know, this is not an answer to this, but that they, had sort of caught up to men. I don't know why I just associate smoking more with men than women, but that's just me. But yeah. So anyway, can you speak to those?
Well, women have caught up to men, unfortunately. This is a bad way of catching up. And again, lung cancer used to be incredibly rare in women, and now just as many women will get lung cancer and die from lung cancer as men. The reason why the percentage of people who are eligible for screening CTs get them in comparison to, say, colonoscopy or mammogram is purely an issue of education. It is not a finance issue. Screening CT scans received a grade B from the US Preventative Task Force, meaning that Medicare and Medicaid will provide screening CT for those who are eligible with no cost sharing. And that was part of the Affordable Care Act. So this should not be a financial issue. The challenge is that people don't know about it, even though screening CT scans have been available for a decade and approved by the FDA, and clinical trials have demonstrated this significant advantage to getting them. Too few primary care physicians are ordering them, too few patients are asking about them, and simply too few people are getting them. And if we can just increase that number to be on par with colonoscopy and mammography, we will make a big difference. Let's look at mammography. It used to be that women didn't get their mammograms either. Back in the 1970s, women didn't talk about breast cancer, and they certainly didn't talk about getting their mammograms. So what's changed? What's changed is advocacy for women. We have advocates. We have advocates for breast cancer. We have advocates for colon cancer. We have advocates for lung cancer, but we need more, and it comes from advocacy.
This is so interesting. I'm just kind of thinking out loud here based on what you're saying, Dr. Hanna. So, you mentioned the cost. I imagine that people aren't aware that the cost can be covered. And then also this sort of process of sort of behavior change in terms of the perception of risk. You have to be aware that smoking is bad for you. You have to understand what happens. Maybe you think it's going to affect you or maybe not. Your attitude towards smoking, and then but your belief that quitting might be a good thing. And then also your sort of like the advocacy. Smoking is something that is socially acceptable. Having breast cancer, it's not something that we promote. It's socially acceptable to have breast cancer. It's socially acceptable to have colon cancer. Anything, would you just speak to that I'm just thinking out loud here. Just wanted to get your thoughts.
What you're referring to is the stigma and the guilt that's associated with lung cancer. It's the stigma and guilt that patients feel. In fact, even people who have never smoked who get lung cancer feel that stigma. And that stigma is very harmful. First of all, no one deserves lung cancer. It is an awful, awful disease. No one deserves it. Secondly, if you feel that stigma and that guilt, you're less likely to advocate for yourself, and others are less likely to advocate as well. Where does that become harmful? Not only on the psychological and emotional well-being of patients and their families and their loved ones, but when it comes to things like research. And we know that there are far fewer research dollars provided to studying lung cancer than many other causes of illness and death, which affect far fewer people. And frankly, that's really unwise, because when you support lung cancer research, you are supporting cancer research. That's because what underlies lung cancer, what causes lung cancer, can help understand, it helps explain and understand many of the things that cause other cancers as well.
That is such a great point, right? It's sort of it's very complex, but it's sort of adding to the body of knowledge of all cancers. Gosh, and then, I mean, it's very difficult I actually worked on an NIH project. It was called Strength to Quit with my doctoral advisor, and NIH study. And we sort of did a randomized control trial about exercise, if it can attenuate the cancer, sort of the addiction. And it was successful. That's just sort of a side note. But how do we go about quitting, or even thinking about quitting? Because, right, we have to think about it first before we decide to take that action. So do you have any sort of suggestions of someone who is considering quitting, but it's very difficult? I mean, what is it? It takes a person 7 times before they actually quit.
Well,
I don't know. That was the number that I was told, but anyway,
yeah,
please.
Or more. Okay, so the messages are very simple. If you don't smoke, don't start ever. And if you do smoke, let's quit smoking. It is a very powerful addiction. If you try to quit smoking on your own, there is a 3% likelihood you will be successful long term. Now, some people are able to do that. It's 3%. Cold turkey is a largely ineffective way of quitting smoking. Just because you tried quitting in the past and were not successful at permanently quitting doesn't mean that has to define you moving forward. You can be successful the next time, or the next time, or the next time. That is the nature of addiction. The nature of addiction is relapse. That happens with all addictions. And so we have to understand that this is an addiction, and it has to be handled in a professional manner. It's a 2-pronged approach. It's both behavioral modification as well as pharmacological intervention. The brain is addicted to nicotine, and it's probably been addicted since somebody was a teenager, and that's a very powerful addiction. So we have pharmacological ways to help with that without exposing the person to all the cancer-causing substances in the cigarette smoke. Because people are not smoking to get the carcinogens, they're smoking to get the nicotine. The behavioral component is very important. You have access to professional counselors for free. You just have to call the CDC supported quit line, 1-800-QUIT-NOW. We have a very robust tobacco cessation program as well at the IU Simon Comprehensive Cancer Center. We can help you quit as well. But at the very least, you can call 1-800-QUIT-NOW. That is a CDC supported. It doesn't cost you anything to do it. It's free, and it's free tobacco counselors.
These are great things. And in terms of the process or thinking about how to quit, well, actually, it's all about prevention. If you're not smoking, don't start. From what I heard, it's also it is possible to quit, but then we want to make certain that give the percentage that cold turkey, you can't do it alone, or cold turkey is ineffective except for that 3%. Just please correct me if I'm not hearing.
You're right.
So we have the 3%, and then we also it's addiction, right? You said, interestingly, we're not smoking to get the carcinogen, we're smoking because the nicotine, and our brain chemistry changes. So it is an addiction. So I'm thinking about what I heard you say is sort of people that you need to change. enter your life, whether doctors, counselors, hotlines, maybe places where you're likely to see smoke or be around smoke? And then what about alternatives to smoking? Is that something that someone can think about when they have that sort of craving, when they're underway, and or when they have that craving? And then also, of course, prescriptions are available.
Yeah, well, my advice is to follow evidence-based approaches to quitting smoking. What we know works is a combination of the behavioral changes with the pharmacologic intervention. But to be frank with you, I am so happy when I hear anybody say, I want to quit smoking and I'm going to try. That is the most important first step. Without that, nothing else happens. And so, look, occasionally people can quit cold turkey. I don't advise it as the most effective way, but I'm encouraged by the fact that they're trying. Maybe they try something that really has a placebo effect. To be honest with you, that's better than cold turkey, because 10% of the time people quit with the aid of something that's really not doing anything for them, but they think it is. That's a placebo effect. That's where a lot of our home remedies come into play. They're really not. If you did a randomized trial, you would find it's no better than placebo. But remember, placebo is better than nothing. So that gives you about a 10% quit rate. If you combine the best pharmacologic agents that we have with the best counseling, there's a 50% chance that you will not be smoking after about 90 days. And to be honest with you, that's the approach you can take. These other approaches like vaping and alternative products, honestly, I see that as a last resort. If you can't quit doing anything else, it is risk reduction. And the FDA has recently recognized it as risk reduction. And it's just an alternative vehicle of getting nicotine. That's really what it largely is. I don't think it's the safest approach, to be honest with you, to inhale anything irritating into your lungs. And so I don't advocate for it. But honestly, if it's between that and a cigarette and nothing else that you've tried works and you're unwilling to do other things, look, I'll support anything it takes for you to get off those cigarettes.
Wow. Yeah. Once doctor told me, she said, don't put anything in your lungs except for air. And I was like, I agree. But all right, for some people, it's very difficult. And I love what you said in terms of, I have the desire to quit. Either prevention, maybe, and then prevention, of course, always first. Don't start smoking. But then, if you are addicted, it is an addiction. When someone comes out and says, "I have the desire to quit, and I'm going to do what I can to quit," I mean, that's great. That can really hit your bones. When you hear someone say that, as a doctor, I imagine, I don't know, when you hear someone, those words are very powerful.
And you mentioned the bones. There are so many adverse health effects from smoking, some of which we know about, some of which I don't think are common knowledge. For instance, it makes your bones thin very prematurely. And so this can be a problem for people who don't exercise, as they get early osteoporosis. It's terrible on your gums and on your dental hygiene. Most people who are longtime smokers, they end up getting dentures, they end up having a lot of gum disease, not to mention all the chronic problems with emphysema, risk of stroke, risk of heart attack, and a myriad of cancers. It's not too late to quit smoking. We know that the adverse effects that come from smoking begin to reverse themselves when people quit. If you've smoked for 30 years, and you quit smoking, within just a few days, your cardiovascular system will begin to improve. Your blood vessels will start to dilate. Your heart rate will start to slow down. Your risk of a heart attack in the first year after quitting reduces 50% compared to the person who continues to smoke. Your risk of cancers continually fall as you get further away from cigarette smokes. So I would encourage people, it's the best thing that you can do for your health. And if you qualify for a lung screening CT, talk to your doctor, but I strongly recommend that you get one.
Wow. Dr. Hanna, this was an incredible conversation. Thank you so much. Any last thoughts you want to add?
No, I just appreciate you bringing awareness to this, and I just really appreciate your time today.
Oh, well, we appreciate you coming on for all the work that you do in this area. Thank you so much.
Thank you.
Learn more and get more with Wish TV. Online at wishtv.com, and when you follow Wish TV on Facebook, be sure to check out more great podcasts from the All Indiana Podcast Network now at allindianapodcastnetwork.com.